I talk about some of these hard decisions, but it's an amazing job to have, where you get to see miracles literally on a daily basis. But I'm segueing into, I also care about maternal health here in Spokane and also in San Antonio. We deal with, unfortunately, a large amount of our babies are going through drug withdrawal. In Spokane, we have a problem with especially methamphetamines. In San Antonio, it was more heroin and cocaine. But here in Spokane, we have some really amazing programs for moms to get on methadone or Subutex. And I have gotten involved in their rehab programs, et cetera. Not that I treat the moms at all, but their health is so important for the baby's health. And I care so much about these babies that of course I care about the mom's health when she's pregnant, during the time that her baby's in the NICU, and of course after, because I'm also involved in a organization called Women Helping Women. And if you want to look at your community and make a difference, you empower your women. That woman is not just going to take care of herself, she's going to be important for feeding and nurturing her children. And so in Spokane, we've realized that to really make a difference for our public school system and for our children, we need to get these women jobs. For example, they've really gotten involved in getting women a short degree, like become a painter. And with that job, it's a short amount of time to have a job that actually pays above minimum wage, that allows you to feed your children, allows you to get off of government assistance, et cetera. So that's a segue into moving forward. I'm only going to talk about what I know. And rural medicine, of course, affects all aspects, all humans, men, women, young and old, but I'm only going to speak moving forward on women and children because that's what I deal with on a daily basis. So let's see here. Health disparities between rural and urban women. Let me just see, make sure this is not the NICU. Okay. So rural America represents 75% of the national landmass. We have a lot of space between cities here in our country, but it's home to 22% of US women aged 18 years and older. And 83.5%, at least back when this was published in like 2010, so it's a little bit older, of our non-metropolitan residents are non-Hispanic white, but Hispanics and Asians are the fastest growing rural subgroups. So they have found that rural access to care is difficult. Prenatal care initiation in the first trimester was lower for mothers in more rural areas. And of course, access to care is very important for a healthy pregnancy. Rural women experienced slightly higher rates of hospitalizations with complications during pregnancy in this investigation in 2008. And that's a little older. And I would imagine, based on my experience, that number is just as high, if not higher, as far as some of our difficulties with access to care. When we look at birth outcomes, a 2002 study in Pennsylvania found that women residing in the two most rural types of communities experienced risks of low birth weight and preterm birth similar to those in urban areas. But when they did calculations of infant mortality or infant death, they found a difference. So during this time, 2000 to 2004, infant mortality rates for the United States and its counties indicated a rate of 6.9 deaths per 1,000 live births. Within that, there were a little over 1,000 rural counties with rates that exceeded that US overall rate. And then a subset of the 128 most rural counties found an infant mortality rate twice that of the national rate. One of the things we look at as a measure of perinatal health, pregnancy health, and then infant health is the birth weight. And this is a picture of looking at low birth weight. And you can't really get a picture of this because every state, some states have more rural areas than others, but every state has rural counties and urban counties. And so it doesn't really show it. But when they broke this down by rural counties, they found that the rural counties had a higher incidence of low birth weight, which may be an indicator of less perinatal health. So when we think about reproductive health, they found that rural women are less likely to receive reproductive health services. And rural women relied on female sterilization 35% was their rate at this time, to a greater extent than women living in central metropolitan, which had 24%, or fringe metropolitan, 25% areas. So they also found in a 2006 survey of women aged 18 to 44 in Colorado, found that women in small towns indicated that they planned for contraceptive use less and were more likely to have an unintended pregnancy than women in urban areas. So more likely to have an unintended pregnancy, and then more likely to not receive care during that time. And I can tell you, as far as a utilization of resources, when women have been able to get prenatal care and were able to plan, their pregnancy outcomes are better. So less than 1/2 of rural women live within a 30-minute drive to the nearest hospital offering perinatal services. And then according to a 2006 birth certificate data, home births were higher in counties with a population size less than 100,000. Rural women aged 18 to 64 reported delayed care or no medical care due to cost and no health insurance coverage. And both of those rates are increasing over time. So here's where I'm going to switch a little bit to other measures of disparities, and that's pediatric versus adult. And I think our rural communities, even though this isn't rural per se, our rural communities see this, and they see it in a more exaggerated and more likely to have severe consequences setting. So I am a member of the American Academy of Pediatrics. I'm also a member of the Washington chapter of the American Academy of Pediatrics. And one of the Washington chapter of American Pediatrics' biggest issues, or thing they've been really fighting for, has been to, of course, give children access to timely health care. And to do that, they have been pushing Medicaid, Medicare parity. So the Washington chapter of the American Academy of Pediatrics supports ensuring timely access to care for all children in Washington. And they think we can better do that by providing funding for Medicaid payment for pediatric care equivalent to Medicare rates. You can see this little chart for the same diagnosis, the rates that Medicaid, which is our children's insurance, pays versus our Medicare, which is our public health insurance, but more for adults, and then private insurance. So for example, a child comes in and has a diagnosis of asthma. An adult comes in and has a diagnosis of asthma. The child's reimbursement for that pediatrician is significantly less. And it probably takes more time because it's probably a new diagnosis. And they're probably doing it in a well child visit, which then also has to go through nutrition and growth and a test on learning and reading and et cetera. And so their reimbursement rates are so low that actually the pediatrician, by the time they stock their vaccines, et cetera, is probably losing money on the Medicaid patient. So the Washington chapter of the American Academy of Pediatrics is doing a very strong push to speak up for our kids. And I kind of just went through and looked at my recent emails and just plopped them in to show what's happening currently. And they're really wanting us to speak up for our kids, because a child with untreated health problems is more likely to have cognitive, behavioral, or physical disabilities during childhood, and then to go on to develop chronic health problems as an adult. So investing in our children is actually going to make our health insurance programs cheaper later on, because these children hopefully will grow up to be healthy adults if they're able to get services. Whereas if they're not getting services, we're just making our Medicare programs more expensive. And so they're really pushing us as pediatricians to tell Washington's legislators to bring Medicaid, or telling everyone, please tell your legislators to bring Medicaid rates to parity with Medicare. The issue is in Washington, 1 out of every 2 children have Apple Health, which is the Medicaid program, for kids insurance coverage. But in many communities, coverage does not lead to access. So currently the Medicaid payment for pediatric care is 2/3 of Medicare rates and does not cover the cost to provide care. So in the cities, a lot of times offices will say, okay, I'm going to see this percent of Medicaid, and the rest I'm only going to see private insurance, because otherwise they kind of subsidize each other. But in our rural settings, there's less and less private insurance, and more Medicaid is the only insurance that these children have. And so as a result, like I said, clinics throughout the state limit or no longer accept Apple Health for kids. So having the insurance doesn't ensure that they're going to get care. And this makes it very difficult for families to access care when their children need it. and this is just an email that I copied and put in here, that their that our society is telling us is please, 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 let's push to bring Medicaid payment to not above. We're not saying that our children should be more important than our adults, just as important as we value our public health insurance. You know, as a neonatologist, sometimes it will be the middle of the night and I have a really sick baby and I'm needing an x-ray. So I call the x-ray tech and I'm like, who is more important in this hospital right now than a sick baby? Leave the ER, come up to see the baby. This baby has more potential than anyone else in the hospital. And I would say that again, as we're thinking about health insurance for our children, you know, lack of timely preventative care. If these children aren't able, we as a healthcare system, we actually reimburse pretty well for the fancy, expensive tests. Our public health insurance pays pretty well for a cath procedure, for some of the new fancy labs, for some of the new fancy tests, but we don't reimburse well for a lot of our preventative care, which I think we just need to have a shift in our value system, because lack of timely preventative care leads parents to rely on expensive episodic care. It's much more expensive to go to the emergency room than it is to go to your pediatrician, and this can delay treatment as their child's condition worsens. Also, a child with untreated health problems is then more likely to experience cognitive, so it's a taxing system on our schools, behavioral or physical disabilities during childhood, and then to develop chronic health problems as an adult. Also, a child with access to a medical home, and that means a medical home just means that they have a pediatrician, a family medicine doctor, someone that's accepted them and sees them on a regular basis, so a primary care doctor. Is more likely to want to graduate from high school, attend college, and have higher income as an adult. So it's an investment that we need to do. The other thing is that kids make up half of Medicaid enrollees, but they only account for 19% of the costs. And preventative primary care keeps kids out of expensive emergency departments, urgent care clinics, and then I'm saying this over and over again, same thing. I would also mention that this has been really highlighted, our access to appropriate behavioral health care for children. This has been an ongoing kind of mounting problem. The pandemic has just highlighted this. Within our state, we have an inpatient unit in Spokane and an inpatient unit in Seattle. Both have very, very long waiting lists. Our rural areas have a very, very hard time accessing psychiatry and behavioral health medicine. Unfortunately, though, behavioral health disorders affects up to 1 in 5 children in a given year. And this is old data. This doesn't include our COVID data. And historically, this 80% of these children don't get treatment. And like I said, this has been exacerbated by the pandemic. Early diagnosis and evidence-based treatment is critical to help ensure healthy development and prevent problems at home, at school, and with peers. Let me just move this so I can see what I'm trying to say. But we need to increase the Medicaid rates for behavioral health and primary care and for behavioral health professionals to improve access to care. Less and less people are going into pediatric psychiatry, less into pediatric developmental or behavioral medicine. And we need to fund Washington's mental health referral services for children and teens. We need to ensure a healthy start for parents and babies to extend postpartum coverage. In Washington, Medicaid pays for pregnancy, delivery, and then just 60 days postpartum care for pregnant individuals, up to 198% of the federal poverty rate. We have an estimated 10,000 people lose their Medicaid coverage just 60 days after giving birth because they no longer qualify for coverage under the current law. This leaves new moms at risk. So not only as a country are we not giving maternity leave for very long compared to other countries, we then also take away their health insurance in a time that these moms absolutely need coverage for their physical and mental health. And these last, I just have a couple slides left. I basically just went through my recent emails and plopped them in to say what is now, those last few slides were what the Washington chapter of the American Academy of Pediatrics is really focusing on. The American Academy of Pediatrics, countrywide, is really worried about our vaccination rate. So during the COVID pandemic, childhood immunization rates have fallen drastically, leaving children, families, and communities at risk for a secondary outbreak. And we're working on legislature for this. So those of you in pre-med, it's not just about medicine. You also need, we love it when we have a law and medicine degree in medicine, because advocating for our children is super important as well. I'm not going to go into all this, but basically just during the pandemic, I think we saw a heightened concern in our cities, but especially in our rural areas, that there was less access to care. Clinics were closed. People were afraid to see their doctor. And in a time when some of these clinics are really struggling, especially in rural areas, because they have, sometimes even if you have a low reimbursement rate, you can see really quickly. Well, now there's less people being seen. And now when they are starting to come back, whoa, they're heightened list of problems. Kids without vaccines, that's an extremely difficult issue for rural America, rural Washington. Children haven't had access to nutritious foods. There's less programs in the rural parts of our states. And so there's just a lot of areas of disproportionate impact. I think our schools being closed, people in higher socioeconomic status have just continued to send their kids to private school, whereas a lot of families that can't afford that can't afford to not go to work. So their child is trying to learn school through a computer with no supervision at home. And I'm worried about what we're going to see as far as mental and physical health in the coming years. So finally, I think that we can still, there are many programs in place, many incentives in place, and some of my rural colleagues are some of the best physicians I've ever worked with. And so I do think we can continue to work together, and we can help our children and adults in rural communities thrive. And I hope I left, oh yeah, we have plenty of time for discussion or questions.
Hello, Lisa. My name is Tanner. I am a pre-med student here at Walla Walla, and I'm planning on going on after medical school to be a rural physician in under communities. Yeah, and I actually did a very long research paper on this subject, and one of the concerns that I had was, where are these resources coming from, and how much of that is going to be government aid and just donations, and how could we maybe even change the culture of rural America so that we don't need as much just aid, right? And so that actually it becomes a self-supporting system, I guess.
Yeah, so there's a few things. We have identified that we need rural physicians. And so there's some great incentives as far as like loan repayment programs, et cetera. And we have, some states have realized within their payment plan that they need to pay more for certain areas, or there's certain grants, or, the problem with some grants and some, we don't want just a year-long program. You need something that's going to be sustainable. And so there are more and more societies, like there's a Rural America Society, there's a rural medicine, I think even within Washington, that is strongly advocating for funding and long-term, success. And I think as far as, not depending on that, I think we're going to continue to depend on that. We have looked in America as, this, you work hard and you do well. Well, I don't necessarily think that different jobs necessarily don't reimburse as well. And it doesn't mean that those aren't hardworking individuals. And it doesn't mean that our Medicaid and our Medicare programs are really important. But as a rural doctor, you're going to have a large proportion of your patients with that type of insurance. And you still need to find a way to leave your lights on, to pay your staff, to keep your vaccines in stock, and all that costs money. And so there are federal and state subsidy programs that are going to be in place and aren't just going to be a one-year program. They're in place for the long term.
Okay, thank you so much.
Mm-hmm. I don't know if I shared this story, if I already shared it. I'm so impressed by my rural medicine colleagues. When I was in San Antonio, we would get these calls. Hey, there's this really sick mom. She's about to deliver an extremely premature baby. We need you. And, by helicopter, we could get almost everywhere. We were to the point that like we were timing ourselves. We could be on the helicopter in the air within 10 minutes, even with all of our equipment. But once in a while, the weather was bad and we couldn't go by helicopter. We had to go by ambulance. And the fact that some of these colleagues, these physicians could deliver the baby, take care of the sick mom, keep this sick baby alive until we got there, I was so impressed.
I'm wondering, what do you think that the emotional and mental health challenges to healthcare providers in this situation are, and how to deal with those?
Yeah, I think there has been, a flux in emotions. I think now that most of us are vaccinated, some of the anxiety for our own health is dissipating. I remember when it was when we first were entering the pandemic. Of course, we're still going to work, but there wasn't always the protective equipment. There wasn't always masks available. There was like a nationwide shortage. We were worried that we were going to run out of ventilators. I remember when my adult floor was getting really busy, they were like, hey, can we take one of your ventilators? I was like, absolutely not. Your patient might die. With a ventilator, my patient's going to live. We were really worried about having the resources to care for our patients. And we were worried about getting sick and dying ourselves. Like I said, with the vaccine, you can almost feel the relief for our own health. I had some colleagues that for a time there were literally coming home, walking down to their guest room and didn't hug their children for a couple months when the pandemic first hit. And just anxiety over what were our resources to care for our patients going to look like. I think now in the NICU, I have never seen a flux in my patient. Like people are still having babies and their sick babies are still coming to the NICU. So I haven't seen this like lull and then overwhelmingly coming back. But I know in talking to some of my colleagues, it's hard to do telemedicine. You don't have that same patient connection. I will say in the NICU, of course, I'm still wearing my mask. My parents are wearing their masks, and having a difficult conversation with a mask in place. I just hope that my empathy comes through. I feel like some of my ability to connect is different with the parents, even with something so simple as a mask in place. I know in primary care, there's a real strong concern that children are still not, parents are afraid to come in and get their kids their vaccines just because there's still a lot of fear out there. And so pediatricians are really worried about the health of their children. I know I'm friends with a CPS worker here in Spokane, and our number of hospitalizations for child abuse has skyrocketed, but our number of reporting has gone way down because our teachers and our pediatricians were big reporters and they're not coming into contact with children. So yeah, I think there's a lot of anxiety and concern right now, with the hope of hopefully we're emerging from this with the vaccine.
How do you personally cope with losing patients, even babies, right? Because I'm planning on possibly going into ER and
Yes.
that can be hard. And how do you fight against burnout?
That's a great question. I remember the first baby that died when I was an intern. And actually on my drive home, I have this like really strong memory of like sobbing to the point that I had to pull over and call my dad. And I still call my dad sometimes after a bad day, but calling my dad and just being like, I don't know how I can do this. Like this baby's life is gone. And my dad was like, with time, you're probably going to become calloused. And I don't think with time I've become calloused. I think with time, all of my population would die without NICU care. And there's a redirection of care, I don't ever stop giving care to my babies, but there's times that I transition to what I call comfort care. And I'm then now caring for the parents and I'm giving this baby dignity. And there's sometimes that medicine just can't do it. And there's also times that living through something is worse than dying from it. And knowing that there's some things that are not up to me, they're up to God. And just going in every day, knowing I'm providing a service for my population. And really basking in the success. We have more babies go home that should have died than babies that die surprisingly. I feel like it's such an honor to be part of a family's major crisis. I mean, no one wants to have their baby in the NICU, right? No one wants to come to the emergency room. That's not something you plan on, but you can be there for them even when you don't have that perfect outcome. And there's days that you're like, hey, I had that amazing catch. If I hadn't been there, this baby or this car accident or this, you name it, whatever you go into, I was trained to deal with this and I showed up for this family. And that is, I mean, I've never done drugs, but it's a high that you just have to bottle up and remember for the days that it really doesn't feel good.
That sounds really powerful. Thank you.
We need to close this up because there's a next session coming in at 1 o'clock. I need to get ready for that. Thank you very much, Dr. Elise McGill-Vargas, for being with us today and making this presentation. It was wonderful, and I'm sure it impacted many, if not all, of our students.
Okay.
Thank you. And we'll talk to you soon.
Okay, sounds good. Have a good day, guys.
Bye. Remember, if you are in the class, to turn in your report.